A very good evening, everyone, all the Wincars members. And this month onwards, we are starting this monthly journal club sort of activity. So to start with here, myself and Dr. Majella will be discussing the trials, the important trials of last year, which will have especially a good impact on our clinical practice. So I'll be trying to go through the trials one by one. So let me start with the optimum trial, which was about the outcome of percutaneous revascularization for management of people who were ineligible for surgery with either multivessel or left main CAD. And these are the results which I'll be discussing with you in short. So there were 750 surgically ineligible people, and PCI was done in 726 people. Primary objective was 30-day in-hospital mortality in PCI cohort compared with STS surgical risk. So if we see the profile of these patients, poor distal targets, severe liver dysfunction, severe lung disease, patients were frail, 9.7% around. Prior sternotomy was also issued, advanced age. So all those criteria which make patients clearly ineligible or little less eligible for surgery. So angiographically, these patients were having severely calcific stenosis. Bifurcation were too many. CTOs were many. And lesions more than 20 were 78. So clearly, I mean, we can, as an interventional cardiologist, we can understand that they were all high risk intervention patients as well, almost. So procedural outcomes, if we see that syntax score before procedure was around 32, and post procedure we could reduce it to 15. So of course, I don't expect that complete revascularization might have been done, but at least operator was able to reduce syntax score to a quite extent. So surgical risk prediction, 30-day in-hospital mortality, 6-month mortality. STS mortality was 5.3 plus minus 5.7, and observed 30-day in-hospital mortality was 5.63. So 30-day mortality and 6-month change in health status according to completeness of revascularization. If we see 30, then people who could achieve syntax score less than was 3.9 in comparison to syntax score of more than 8. And if we see the overall health status, the quality of life, the angina frequency, so there were clear-cut change which was achieved. So yes, most of the times we nowadays we are seeing the patients who are not eligible for surgery either. So we can maybe try to do whatever reduction in syntax score we can do, we should try to do that, despite the very difficult and anatomy which we have to deal with such patients. But still, the patients will be getting benefit by it. Now, second, I come to patients with high bleeding risk undergoing PCI represent a challenging patient population. So in them, the use of DCB allows shorter duration of DAPT compared with the stent and reduces thrombotic risk due to absence of a permanent implant. So this was basket small 2 trial. This is another very common subset of population, our patient, which we see day in and day out. And this analysis was aimed to see if the effect of DCB versus DES differed between patients with and without HBR treated with PCI in small coronary arteries. Though it is already discussed in any studies previously, the drug, this cutting balloons, the use of cutting balloon, small arteries especially, the coated balloons, they are quite effective and they are quite a solution, especially in the arteries where small arteries where either stent cannot go or stent size is very small. And if ISR happens, then it's a difficult thing. So if we see the schematic representation of the effect of DCB on ISR and de novo lesions, this is ISR and post PCB follow up like this. So results are not bad actually, at least diagrammatically. If we see the summary of treatment effects for paclitaxel coated balloon, this is alternative treatments. So possible explanations are lower DAPT dependence, less neoatherosclerosis, less additional stents in ISR, and lower vessel and lesion thrombosis. So this trial profile, 883 patients with percutaneous coronary intervention assessed for eligibility. Pre-dilatation was done. If successful, then 758 were allocated to treatment and included full analysis set. 382 were assigned to receive DCB and 376 for stent. So the follow-up, 370 followed up at 12 months and included in pre-protocol set, and 359 followed at 12 months, including pre-protocol set. Flow-limiting dissections or residual stenosis about 30% during pre-dilatation. 125 patients were in this category, and they were assessed in a separate registry. So primary and secondary endpoints at 3 years were seen, and if we see the MACE, death, MI, TBR, and ST, stent thrombosis. So in a drug-eluting stent, MACE was completely same, and death was less in drug-eluting stents, MI same, and TBR same. So as far as the TBR is concerned, it seems to be very important event for us as far as because the procedure is also a problem. So this indicates a good outcome. So event rates with DCB and DES in de novo coronary lesions of diabetic and non-diabetic patients, they compared. So MACE and TBR, they were not very significantly different from each other. Outcomes of 3-year follow-up according to clinical presentation in chronic coronary syndrome and acute coronary syndrome. So these were the data presenting. And acceptable angiographic results, no flow limiting dissections, residual stenosis less than 50%, FFR was more than 0.8. So optimal lesion preparation, pre-dilatation, standard semi-compliant balloon, options, rotablation, lithotripsy, FFR, IVS, OCT for ISR. And then it was decided to go for DCB or DES. Then coming to SWAP trial, the pharmacodynamics and pharmacokinetic profiles of switching between Cangrelor and Ticagrelor following Ticagrelor pre-treatment. So a little something little different from what we saw and what we practiced so far about the Ticagrelor and Cangrelor also. It's a prospective randomized double-blind placebo-controlled. It was a crossover pharmacokinetics dynamics trial. Patients with stable CAD on low-dose aspirin for at least 1 month were randomly assigned to either Ticagrelor loading dose, followed after 1 hour by Cangrelor bolus and infusion for 2 hours, or Ticagrelor loading dose, followed after 1 hour by placebo bolus and infusion for 2 hours. Because it addresses the different kind of population in which we have been not using Cangrelor so far. So it opens some new possibilities for us actually. So it not only provides further data on the absence of drug-drug interaction between Ticagrelor and Cangrelor, but also suggests that Cangrelor administration patients pre-treated with Ticagrelor produces faster platelet inhibition. And this finding is unique, but opens the debate on new therapeutic hypotheses that warrant validation in terms of clinical endpoints. And it includes patients with stable CAD, which were pre-treated with Ticagrelor. So the evidence on antithrombotic strategies does not support systematic administration of a potent P2Y12 inhibitor, such as Ticagrelor in patients with stable CAD, and current guidelines do not recommend pre-treatment like this. So the results of this SWAP-5 trial are reproducible in STEMI setting. In fact, in patients who are vomiting and all, we are giving Cangrelor injections, but not the bolus, not the infusion followed by bolus, most of us. So in agreement with previous evidence from TENTIC trial in which patients received Cangrelor and Ticagrelor at the same time, this trial indicates that drug-drug interaction between Cangrelor and Ticagrelor can be safely excluded regardless of clinical presentation. So the results of fabulous FASTER trial shows platelet inhibition by Cangrelor overall tend to be lower compared with those of SWAP-5 and TENTIC trials. The short half-life of Cangrelor is key in preventing bleeding events. And in contrast to trial of Ivan, effects last several hours with relevant implication and major or life-threatening bleeding event occurs. Talking about next thing, the comparison of a precision care strategy with usual testing, guide management of stable patients with suspected CAD, precise randomized trial. So it is a comparison of a precision care strategy wherein we are strategizing our patients' care precisely with usual testing to guide management of stable patients with suspected CAD. So population is new onset of stable chest pain without any previous history. Intervention group, we stratified using PROMIS risk score. Low risk was not tested. Only guideline medical therapy was given. And high-risk patients, they underwent CTA with FFR-CT for stenosis more than 30 and less than 90. And in control group, usual diagnostic strategy consisting of functional test or direct diagnostic angiography as we do routinely on clinical practice. Randomization was done 1:1, and 21% of low risk in both arms patients were there. Elevated risk 93% tested in precision versus 94% in usual. And follow-up was completed in 96% of patients with a median duration of 11.8 months. And the findings were 65% reduction of death or non-fatal MI or non-obstructive CAD, 70% reduction of invasive coronary angiography, which is a very important implication for all of us as an intervention cardiologist and our society as a whole. Important economic and safety implications, and net clinical effectiveness and a reduction of futile invasive coronary angiography by applying the precision diagnostic strategy in low intermediate risk of patients presenting with the chest pain. So we know these trials, these impact studies, Scott Hart and PROMIS. We have seen the successful use of CT angiography as a first test routine in assessment of suspected CAD in patients presenting with stable chest pain. In fact, 2021 ACHA guidelines, diagnosis of chest pain promoted the CTA in class 1A and first-line diagnostic test for intermediate risk patients with stable chest pain with a further assessment using FFR-CT or stenosis from 40 to 90% proximal or mid coronary arteries, class 2A. So non-acute chest pain, no history of obstructive CAD or CAD testing less than 1 year. Randomization stratified by preferred first test, usual care, and PROMIS risk score. And composite primary endpoint, effective chest pain evaluation at 12 months. MACE, obstructive CAD, FFR less than 0.8. Secondary endpoints, hierarchical analysis of primary endpoints, resource use, quality of life, etc. So the PRECISE will be the first randomized trial to prospectively test the safety and efficacy of a guideline recommended medical therapy with no immediately planned testing approach in very low risk patients presenting with stable chest pain or equivalent symptoms. Once completed, the results of PRECISE will potentially show us an improved evaluation strategy and diagnostic test paradigming for the patients who present with stable chest pain and informing future key policy, practice, guideline decisions. Sorry. While COURAGE, ORBITA, and ischemia were all conducted in patients who already had diagnostic testing, the PROMIS minimal risk tool was developed to identify even lower risk patients with stable chest pain prior to testing who are unlikely to benefit from non-invasive diagnostic testing. And the risk model was developed using PROMIS cohort and employs readily available clinical variables to identify patients with stable chest pain who had no coronary plaque or transfusion and no cardiac events over 2 years, who will be safely managed with guideline recommended medical therapy alone. Now, one more drug, that is indobufen or acosprin on top of clopidogrel after coronary drug-eluting stent implantation. As we all know, we are just talking nowadays that aspirin may be completely out of the cardiology. So this is that time will only tell, but this trial option took 4,551 patients properly negative, undergoing DS implantation, mean is 61. So indobufen 100 milligram BD and clopidogrel 75 milligram UD. versus icosapent 100 milligram and clopidogrel 75 milligram. So this was done in Chinese patients with cardiac troponin negative undergoing stent deployment. And this combination compared with aspirin plus clopidogrel, our usual combination, significantly reduced the risk of 1-year net clinical outcomes, which was mainly driven by a reduction in BARC2 bleeding events in these patients. So this study was done in Chinese patients with negative cardiac troponin, indobufen plus clopidogrel, DAPT for 12 months, and they found it non-inferior to our usual regime of icosapent and clopidogrel with regard to primary endpoint. So largest randomized comparison of the two open label design and lower than expected event rates, 8% versus 6.1 in the icosapent group, mitigate the impact of the study. And advantage of indobufen was confined to less minor bleeding events rather than an improvement in ischemic endpoints. And the 12-month DAPT regime is longer than the currently recommended DAPT duration following elective PCI. So the clinical benefit of indobufen begins around 6 weeks, when de-escalation of DAPT by removing icosapent is widely practiced nowadays. So this may limit the application of study results to daily practice. However, maybe some other studies come up. And to conclude, indobufen requires high patient adherence because of its twice daily regime, is an alternative to aspirin in biomarker negative patients undergoing PCI and treated with clopidogrel, particularly in cases of aspirin hypersensitivity, intolerance, or resistance. So maybe we have a just viable alternative option to our icosapent. Then coming, we have been discussing a lot about bivalirudin use, and in past it has undergone a lot of controversy, but now this again is coming up. So bivalirudin plus a high dose infusion versus heparin monotherapy in patients with STEMI undergoing primary PCI, a randomized trial. So this was the population, 6,000 STEMI patients, intervention. They intervened bivalirudin with post-PCI high dose infusion for 2 to 4 hours and control the heparin, our usual heparin. And the results of this study show that in patients undergoing primary PCI who did not receive thrombolytics and were not pre-treated with heparin or bivalirudin, bivalirudin with a post-procedure infusion of 2 to 4 hours resulted in lower all-cause mortality and BARC 3 to 5 bleeding at 30 days compared to heparin treatment. And it resulted in lower stent thrombosis with similar rates of ischemia-driven revascularization reinfarction. Compared to prior trials comparing this kind of strategies, this trial is a little unique in so far because as a post-PCI of bivalirudin is mandate, even that was hypothesized that short half-life of bivalirudin, its discontinuation immediately post-PCI might have contributed to increased stent thrombosis observed in our previous studies. Bleeding events within the trial were low in both, and excess site bleeding can happen in any strategy. Trial was carried out exclusively in China again, so limiting the generalizability of population worldwide. Though we know that there is no genetic polymorphism to suggest differing anticoagulant effects. But maybe it could be just revival of bivalirudin again for clinical practice. We have to sort. Now coming to sotagliflozin, significantly reduces cardiovascular death, myocardial infarction, and stroke in SCORE trial. We all know SGLT2 inhibitors, DAPA-HF reduced recruited ambulatory patients with heart failure reduced extraction with or without diabetes. Differently in soloist WHF, the study population was recently hospitalized people who all had type 2 diabetes and covered the entire spectrum of EFs. Participants in the later trial were at a high risk for CV events, as indicated by the placebo event. For the first CV death or hospitalization, which was 48% in soloist WHF compared to 25.5 and 28.5 in DAPA-HF and heparin-induced, respectively. These data emphasize the potential of sotagliflozin to reduce cardiovascular outcomes in very high-risk patients, diabetes and heart failure, and they were not adequately represented in other trials so far. So if we see these trials, SCORE and soloist WHF, and so SCORE was the first trial to show the benefits of class across the full range of albuminuria, and obviously clinically important as it expands the population in which SGLT2 could improve kidney outcomes. Traditional knowledge about the glucose lowering effect of SGLT2 already show that hypoglycemic potency is greatly dependent on kidney functions and progressively declines as the GFR falls. In SCORE, however, reduction HbA1c was seen in participants with eGFR values below 30, probably secondary to reduced intestinal absorption of glucose as a result of SGLT1 inhibition. So taken together, these data suggest that sotagliflozin could offer parallel cardiorenal protection and glucose lowering action in people with advanced CKD and a population where option of anti-diabetic treatment is limited. So coming to next trial, complete trial, quality of life. This trial has shown that complete revascularization reduced CV death or new MI and led to a class 1A recommendation for complete revascularization in 2021 guideline for coronary artery revascularization. STEMI with multivessel CAD and successful PCI to the culprit lesion. So randomization to complete revascularization, staged non-culprit lesion PCI plus optimal medical therapy, 2,000 patients, and culprit lesion only, also 2,000 patients. So if we see the outcomes, median follow-up was for 3 years. The complete trial previously showed that in patients with STEMI and multivessel disease, complete revascularization compared to culprit only was associated with less death and subsequent MI. The current evaluation showed that complete revascularization was also associated with significantly improved quality of life based on the cetal angina questionnaire at 3 years as compared to incomplete revascularization, provided the non-culprit lesion was more than 80%. Residual angina was less frequent in the complete group versus culprit only. If we see first co-primary outcomes between complete and culprit only, you can see the difference, baseline characteristics of the patients taken. And to conclude this trial, at a median follow-up of 3 years, a greater proportion of people were free of angina in complete group than in culprit only group, translating into a number needed to treat of 31 patients to prevent 1 patient from experiencing angina at a median follow-up of 3 years. And benefit was seen entirely in patients with stenosis severity more than 80%. Total angina burden from randomization to follow-up, including all angina-related events and residual angina, was remarkably reduced with complete revascularization. Now, talking about the next thing, FFR and IVUS guided intervention strategy for clinical outcomes in patients with intermediate stenosis, flavor trial. So all of us, we clinically have experienced a lot of FFRs and IVUS guided angioplasties since so many years. Concept is not new to us. However, the results showed that for patients with intermediate coronary lesion, FFR guided versus IVUS guided PCI was non-inferior, supporting use of either technology for effective intermediate lesion assessment. But all of us who are doing these, we understand the implication of each of them separately. It is a randomized open-label non-inferiority trial aiming to compare these two. De novo intermediate coronary stenosis, that is 40 to 70%, by visual estimation of coronary angiography, located in a non-left main target vessel of at least 2.5 millimeter, were randomized to either of the two technologies. FFR, we know the criteria, the standard criteria was followed. IVUS group, the criteria for intervention was luminal area less than 3. So patients a total of 1,600 patients were taken in this. And so we know, so basic point of discussion over here is that in FFR negative patients, we did not include the impact of vulnerable plaques. And FFR use seems to be disadvantageous to assess intermediate coronary stenosis in high-risk patients with MI or diabetes, because we know systemic inflammation, plaque vulnerability. And the combined OCT-FFR trial, FCA was detected in 1/4 of FFR negative lesions of diabetic patients. So this is basically a known concept that not only we have to see the physiological gradient across the lesion, but we have to assess the plaque vulnerability along with other risk factors also. So this, I think, will be taken up by cardiologists as a one-to-one base, not as a generalized conclusion. Now coming to my last slide, very short slide, that can we prevent radial artery occlusion after transradial access using nitroglycerin use? This trial was designed to assess value of intra-arterial nitroglycerin, but it failed to reduce the frequency of artery occlusion, regardless of the timing of administration, sheath entry, or whatever way we did it. And additional secondary endpoint included no difference in radial artery occlusion 30 days, with or without nitroglycerin. However, we all know that it significantly reduces the frequency of arterial spasm compared to placebo. And importantly, intra-arterial nitroglycerin use was associated with a higher incidence of hypotension. That this all we know. So concluding my slides and giving over to Dr. Majella. Thank you so much.
Good evening. On behalf of Wincars, I'm going to discuss few topics, practice-changing clinical trials of 2022. Already Dr. Kavita Tyagi ma'am has done an extensive discussion on many of the trials. Now let's go on to the trials of 2022. A total of 36 studies in 10 hotline sessions were presented in 2022 by the ESC Congress. What was notable in this 2022 edition compared to the prior meetings was the increased number of investigator-initiated trials, some of which had novel findings and potential impact on clinical practice. We are going to see a few of them. The SECURE trial, the secondary prevention of cardiovascular disease in the elderly trial, was constituted of almost 2,499 patients, which investigated whether a polypill strategy containing aspirin, ramipril, and atorvastatin would improve the medication adherence by simplifying the usual care treatment into a single pill. Over a median follow-up of 3 years, a polypill strategy in the older post-MI patients with a median age of 76 years, which constituted 31% women, resulted in a 24% relative risk reduction in the primary composite endpoint of cardiovascular death, non-fatal MI, type 1, and non-fatal ischemic stroke and urgent revascularization, with a significant p-value of 0.02 compared to the usual care. The benefit was consistent across the 16 pre-specified subgroups, and there were no differences regarding adverse events. Adherence levels and treatment satisfaction regarding medication were higher with the polypill arm versus the usual care, both at 6 and 24 months. Our population is increasingly aging, and post-MI survival rates have improved over recent decades. Nevertheless, the incidence of recurrent cardiovascular events remains high despite the availability of effective secondary preventive treatments, and we know that poor patient adherence is associated with worsened outcomes. Therefore, the SECURE trial addresses a relevant clinical question with important implications for clinical care worldwide. The limitations of this study are the increased susceptibility to bias inherent to its open label design, and 14% participant withdrawal during follow-up, probably aggravated by the COVID-19 pandemic, as well as the lower than expected event rates leading to the potential loss in statistical power. The final conclusion of this trial is its results are certainly exciting and will surely impact clinical practice. The SECURE trial investigators are to be commended for having successfully carried out the first polypill trial in secondary prevention. Coming to the ADVERT trial, acetazolamide in decompensated heart failure with volume overload, which constituted 519 patients, is a multi-center, randomized, placebo-controlled pragmatic trial conducted exclusively in Belgium. The trial tested whether combination of intravenous loop diuretic therapy, which acts distally in the nephron, with the diuretic acting at the targeting at the proximal tubule, such as acetazolamide, will boost up the loop diuretic efficacy, especially in patients hospitalized with decompensated acute heart failure. So the ADVERT trial, the ADHF on a background of standardized IV loop diuretic therapy along with acetazolamide 500 milligram IV daily was associated with a higher incidence of successful decongestion at 3 days, 42.2% versus 30.5%, compared to the placebo with a risk ratio of 1.46 and with 95% CI and with a significant p-value of 0.001 in patients across the spectrum of LVEF, representative of current clinical practice at a mean age of 78 years, which included 38% women, and the median NT-proBNP levels in these patients was 6173 picogram per ml. The benefit was associated with a shorter length of hospital stay, but not a lower incidence of all-cause death or rehospitalization for heart failure patients, given the lack of power to detect any differences in this key secondary endpoint. Interestingly, an incremental reduction in congestion over 3 consecutive days in acetazolamide-treated patients were observed, and the effect driven by higher diuresis and remarkably greater natriuresis in the acetazolamide arm, emphasizing the importance of early and aggressive treatment on hospital admission. No differences were observed between the two groups regarding safety. We know persistent congestion at hospital discharge has a poor prognosis, and although only 15% of patients were successfully decongested after 3 days of treatment in the DOSE trial, high-dose IV loop diuretic therapy is the go-to treatment strategy in acute decompensated heart failure patients with volume overload. Therefore, the ADVERT trial addresses the currently unmet need of profound clinical relevance. And nonetheless, given the novelty of the study in proposing an effective, early, and aggressive treatment strategy that incorporates an easy-to-use, off-patent, and seemingly safe diuretic agent, this trial is a home run for Belgium and a decisive step forward in the treatment of acute decompensated heart failure worldwide. Coming to the REVIVE BCIS-2, the study of efficacy and safety of percutaneous coronary intervention to improve survival in heart failure patients, we are now able to see this includes almost 700 patients and is the first trial to have investigated whether revascularization, PCI, has a role in the treatment of patients with severe LV dysfunction and coronary artery disease. Over a median follow-up of 3.4 years, revascularization with PCI on top of OMT compared to OMT alone did not result in lower incidence of primary endpoint of all-cause death or hospitalization for heart failure, with nor any benefit in terms of improved LVF or quality of life scores. Conceived amidst a lack of data across the globe, the guideline recommendations, if any, based on the level of evidence seen, there was hope that PCI could offer similar benefits to those compared to this in the STRITCH trial without the first 30-day periprocedural excess mortality associated with CABG. The points to ponder in REVIVE BCS-2 score. However, this question begs a longer-term follow-up as was done in the STITCH trial. That being said, additional analysis of the trial data are warranted to precisely determine to whom the findings of REVIVE BCS to apply. In the meantime, the facts that the primary endpoint was mainly driven by all-cause death rather than hospitalization for heart failure, and that improvements in LVEF were observed irrespective of the randomized treatment, highlight the importance that optimal medical treatment in this patient population and anticipate continued improvement with the increasing implementation of contemporary heart failure therapies. Now coming to the most important and very interesting trial, the mavacamten for treatment of symptomatic HOCM, the Explorer HCM trial. The Explorer HCM trial showed that mavacamten was superior to placebo at improving exercise capacity and health status. The goal of the trial was to evaluate mavacamten, a cardiac myosin inhibitor, compared with placebo among patients with hypertrophic obstructive cardiomyopathy. It is a randomized, parallel, and a double-blind study. Eligible patients were randomized to mavacamten 5 milligram daily, which included 123 patients, versus placebo, which included 128 patients for 30 weeks, who had class 2 to 3 symptoms. The total number of enrollees were 251. The duration was 30 weeks with the mean patient age of 59 years. And the percentage female who were included was 46%, and percentage with diabetes was 5%. The inclusion criteria were more than 18 years of age or equal to 18 years of age, hypertrophic obstructive cardiomyopathy with the LVOT gradient more than 50 millimeter, and an LV ejection fraction of more than 55%, and the NIHA functional status of 2 to 3. Exclusion criteria was syncope, sustained VT with exercise within 6 months. The principal findings were the primary outcome of more than 1.5 ml per kg per minute increase in PVO2 with more than 1 NIHA class improvement, or 3 ml per kg per minute increase in oxygen consumption with no worsening of NIHA class at 30 weeks occurred in 37% of the mavacamten group compared to the 17% of the placebo group, which was very statistically significant of a p-value of 0.0005. The secondary outcomes of this group post-exercise LVOT gradient changed from baseline to week 30, 47 millimeter of mercury in the mavacamten group versus 10 millimeter of mercury in the placebo group, which is once again very statistically significant. The PVO2 changed from baseline to week 30, 1.4 ml per kg per group per minute in the mavacamten group to 0.1 ml per kg per minute in the placebo group. The cardiac magnetic resonance, the MRI sub-study analysis showed that the change in LV mass index was 17.4 gram per meter square in the mavacamten group versus 1.7 gram per meter square in the placebo group, which was once again statistically significant. The change in LVF, 6.6% in the mavacamten group versus 0.3% in the placebo group, was once again significant. And the KCC questionnaire at 30 weeks, the change in KCC questionnaire overall summary score 14.9 for the mavacamten group versus 5.4 for the placebo, which was once again statistically significant. Therefore, we are able to see the final interpretation that among patients with HOCM, mavacamten was superior to placebo. This medicine improved functional capacity and health status as assessed by the Kansasi questionnaire. Mavacamten was well tolerated with no significant long-term treatment-related adverse events. Mavacamten was associated with a significant reduction in post-exercise LVOT gradient compared with placebo at 30 weeks, which was sustained to 48 weeks. And cardiac MRI found that mavacamten was associated with the favorable remodeling compared with placebo. Now coming to the ADAPT-TAVR trial, edoxaban versus dual antiplatelet therapy for valve thrombosis and cerebral thromboembolism after transcatheter aortic valve replacement, a randomized ADAPT-TAVR trial. 220 patients after successful TAVR procedure, stratified by device type and participating site, were subjected to Novax edoxaban 60 milligram or 30 milligram once daily. The number of participants in this group were 110. And dual antiplatelet therapy, aspirin plus clopidogrel, the total number once again was 110. And the primary endpoint is the incidence of leaflet thrombosis or on 4-dimensional volume rendered cardiac CT scan at 6 months post-TAVR procedure. And edoxaban versus DAPT for leaflet thrombosis and cerebral thromboembolism. This is an investigator-initiated, open-label, multi-center randomized trial. And the leaflet thrombosis at 4D CT at 6 months, and new cerebral lesions on MRI were assessed. And the conclusions of the ADAPT-TAVA trial is that in patients without an indication for long-term anticoagulation after TAVA, the incidence of leaflet thrombosis is numerically lower with edoxaban than with the dual antiplatelet therapy, but is not statistically significant. The effects on new cerebral thromboembolism and neurocognitive function were also not different between the two groups, and this study was underpowered. Therefore, the results of this study, the DAPT adaptive TAVR trial, should be considered with caution, generating and highlighting the need for further research. Coming to the efficacy of diltiazem to improve coronary vasomotor dysfunction in angina and non-obstructive coronary arteries, the results of the EDIT trial, I would like to highlight that the efficacy of 6 weeks of diltiazem treatment to improve coronary vasomotor dysfunction, symptoms, and quality of life, the primary endpoints and the secondary endpoints, it is found that significant improvement in coronary microvascular dysfunction and coronary artery dysfunction was statistically significant in patients who were treated with diltiazem. Coming to the DELIVER trial, the dapagliflozin proves heart failure with preserved ejection fraction benefit in the DELIVER trial. Comparing SGLT2 inhibitors in heart failure with mildly reduced ejection fraction and heart failure with preserved ejection fraction, the primary outcome, worsening of heart failure, cardiovascular death, and the total primary outcome events, the results of the DELIVER trial indicate the use of dapagliflozin was associated with improved primary outcomes and a 21% reduction in risk observed for worsening of heart failure, reduction in risk observed for cardiovascular death compared with placebo therapy. Results of the study build on the evidence from previous dapagliflozin trials, contribute to the idea that the benefit seen in heart failure with preserved ejection fraction could be a class effect for SGLT2 inhibitors. The time study, no added benefit from nighttime dosing of blood pressure medications. The compared from the morning versus the nighttime study, the time study, the use of antihypertensive medications, the primary composite outcomes, non-fatal stroke, non-fatal MI, the cardiovascular death and all-cause mortality, and heart failure hospitalization and death. This study outcomes are, although the HYGEA study produced evidence suggesting that nocturnal dosing could improve outcomes, the results of the time study, the randomized trial, which included 21,104 patients followed for more than 5 years, demonstrate evening dosing of antihypertensive medication did not result in a significant difference in cardiovascular outcomes among patients with hypertension when compared to the standard morning dosing. People with high blood pressure should take the regular antihypertensive medications at a time of day that is convenient for them and minimizes any undesirable effects. This is said by the lead investigator, Professor Thomas McDonough. So coming to the axiomatic SSP trial, whether milvexian shows promise for preventing stroke in phase 2 dose-finding trial, which was randomized patients to placebo, the milvexian at 25 milligram once daily or twice daily doses and were followed up for 90 days. So why I'm just one point about this, the risk of stroke reduction, because this study, it was European Society of Cardiology press release referred to as the largest dose-finding trial of an anticoagulant in stroke patient. This is the trial that provides evidence suggesting the use of milvexian in patients with a prior ischemic stroke and a high risk of transient ischemic attack who are already on dual antiplatelet agents like an MI patient could reduce the risk of stroke without an increase in clinically significant bleeding events. Coming to the finerenone reduces all-cause mortality, sudden cardiac death in type 2 diabetes. This is the fidelity data of finerenone from the ESC Congress 2022. So with pooled data of the Fidelio DKD and the DKD trials, an analysis of the fidelity program has showed that a reduction in risk of mortality and a reduction in risk of cardiac death in patients with type 2 diabetes and chronic kidney disease. But this is the statistics which shows that there are data from the fidelity suggests that use of finerenone was associated with 11% reduction in risk of all-cause mortality and 25% reduction in the risk of sudden cardiac death. On treatment analysis that included up to 30 doses after last dose suggested use was associated with an 18% relative reduction in both all-cause and cardiovascular mortality. Coming to the DANCAVAS trial, the studies showed comprehensive cardiovascular screening will reduce death or cardiac events, and if so, is it cost effective? The trial environment is unique because it will include only men aged 65 to 74 years. This is very unique because this is a study which includes only men who live in the island of Union, the largest in Denmark, with a population of about 500,000 people. 1/3 of the 45,000 men will be randomly assigned to a quite a serious screening regimen that includes CT scans to assess for the coronary calcium, aortic or iliac aneurysm, an ankle brachial index, cardiac rhythm assessment, and blood tests to measure lipids and glucose. The authors used their national registry to assess all-cause death and the cost. The control arm was standard care. And the final results was the universal cardiovascular disease screenings do not reduce risk of death in men. So that is the conclusion of this study. Coming to a few quick screening of certain important other trials, the Perspective trial, which includes sacubitril valsartan and cognitive function in heart failure with mildly reduced ejection fraction and heart failure with preserved ejection fraction. The conclusion of the Perspective trial was sacubitril valsartan does not change cognitive function compared with valsartan alone in patients with heart failure with mildly reduced ejection fraction or preserved ejection fraction. And the impact on clinical practices, the absence of any negative effect on cognitive function is very important in removing a concern because some doctors had about long-term treatment with sacubitril valsartan. And one last point in the last line, which is very important, that it indicates amyloid beta deposition in the brain tended to be less in patients treated with sacubitril valsartan compared with valsartan. That is why there is no much cognitive or no cognitive change in cognitive function in patients put on sacubitril valsartan combination. And coming to the DANFLU-1 trial, this is a high dose versus standard dose quadrivalent influenza vaccine in elderly patients. The conclusion of this trial is the innovative randomized trial shows that high dose influenza vaccination in older adults is associated with a reduced risk of death and lower incidence of hospitalization for influenza or pneumonia compared with the standard dose vaccination. What is the impact on clinical practice? The reduction in hospitalizations and all-cause mortality with a high dose of vaccine require confirmation in a larger trial before potentially guiding clinical practice. And the ALHEART trial, allopurinol and cardiovascular outcomes in ischemic heart disease, the conclusion is this gout medicine, allopurinol, has failed to reduce the primary endpoint of non-fatal MI, non-fatal stroke, and cardiovascular death in patients with IHD. The impact on clinical practices, allopurinol therapy does not improve major cardiovascular outcomes in patients with IHD. The question of whether allopurinol might prevent cardiovascular events in people with heart disease, but no clinical gout, has been around for many years, and this question has now been definitely answered in a robust study. That is the ALHEART study. Now coming to ECHONET RCT. It's a simple thing, safety and efficacy of study about LV ejection fraction in using artificial intelligence. In patients undergoing echocardiographic evaluation of cardiac function, preliminary assessment by artificial intelligence is superior to initial sonographer assessment. The impact on clinical practice, embedding artificial intelligence into cardiac workflows could potentially provide more precise and consistent evaluations, thereby enabling early detection of clinical deterioration or response to treatment. The FRAME AMA trial, with FFR versus angiographic guided PCI in acute MI with multivessel disease. This is a very important trial that concludes that selection of non-infarct related artery lesions for intervention using FFR is superior to routine angiography based selection in patients with acute myocardial infarction and multivessel disease. The impact on clinical practices, interventional cardiologists may choose to opt FFR guided decision making in patients with acute MI and multivessel disease. The eBrave AF trial, a smartphone based AF screening. The conclusion is atrial fibrillation screening using conventional smartphones more than doubles the detection and treatment rate in older people compared to routine screening. The impact on clinical practice is the app-based pre-screening was only one part of the program, which also included ECG validation and assessment of the findings by an independent physician. The eBrave AF trial, the final conclusion is atrial fibrillation screening using conventional smartphones more than doubles the detection and treatment rate in older people compared to routine screening. The impact on clinical practice is the app-based pre-screening was only one part of the program, which also includes the ECG and validation and assessment of the findings by an independent physician. So again, definitely this trial, which constituted for almost 6 months, which is a randomized trial, the smartphone AF screening with compared to the conventional AF screening was definitely much beneficial in these subgroup of patients and almost doubles the detection rate and treatment rate in older people compared to the routine screening. Now coming to the Invictus trial, the rivaroxaban versus VKA for rheumatic atrial fibrillation. The conclusion is their largest trial in patients with rheumatic heart disease has found that in those with atrial fibrillation, vitamin K antagonists reduce cardiovascular events and mortality without increasing major bleeding compared to rivaroxaban. In this group, which constitutes almost 4,565 patients who were randomized and given rivaroxaban 20 milligram once daily and adjusted VKA, vitamin K antagonist, with a median follow-up of 3.1 years. And the impact on clinical practice is that adjusted dose of VKA should remain the standard of care for patients with rheumatic heart disease and atrial fibrillation. With that, I conclude the trials, though within a short duration of time, myself and Dr. Kavita Tyagi has given in nutshell all the important trials of 2022, which has an impact on clinical practice. On behalf of the Wincars, thank you so much.